Upon re-review of the original images from the first examination, we can see the ovary was located deep in the cul-de-sac posterior to the uterus, and the diagnosis of torsion should have been made more strongly. Other images from the original study, we see this curious cystic structure in the left adnexa adjacent to the left ovary. Now this almost has the appearance of an ectopic pregnancy, and in fact, query was made as to whether the patient presenting with pelvic pain was pregnant. The beta HCG test came back negative, but I want to point out here the blood vessels that are wrapping around this structure, and this represents the twisted vascular pedicle in the setting of torsion. It's been sometimes described as a target sign or a whirlpool or a snail. And this is a blood clot in the pinched off fallopian tube. To better illustrate this, we see a cine clip through that adnexa. You can see that as we scan through this, you can see the blood vessels swirling around. Show you one more time, again illustrating the twisting of the vascular pedicle, in this case of torsion. These images were provided by Dr. Fei Lang. We see a patient with left lower quadrant pain. We again see an enlarged left ovary. Follicles are displaced to the periphery, hemorrhage within the ovary. On this transabdominal view, we see the uterus and the ovary that is enlarged. You can see its size relation to the uterus. You can also see that the ovary is displaced into the cul-de-sac and posteriorly. But when Doppler was performed, there's exuberant flow within this ovary. Is this a case of torsion? Well, this is a case of torsion and detorsion. When the ovary detorses, there is compensatory increased flow into the ovary, which can present with this appearance. Here is a patient who presents with suprapubic pain. It is important in patients with ovarian torsion to perhaps look for a leading point or a mass that may cause the torsion. Now, because this patient presented with suprapubic pain, a CT scan was ordered. The on-call reading was correctly made of a dermoid cyst involving the ovary. You can see the fat within the cystic structure. But because the patient was presenting with pain, a transvaginal study was performed to exclude torsion. Images of the right ovary demonstrate the classic appearance of a dermoid cyst. We have a component made out of the sebaceous material, composed of low-level echoes. We also have an echogenic nodule and some linear echoes relating to the hair within the dermoid cyst. Now, Doppler failed to provide any vascularity or any detectable vascularity. In cases such as this, it is difficult to tell what part of the ovary can be interrogated for vascularity, as the ovarian parenchyma may be unidentifiable or stretched or thinned by this large dermoid cyst. So in this case, the ultrasound reading could not help to determine the torsion, but upon re-review of the CT images, we can see that the ovary is displaced anterior to the uterus and superiorly. So we know that this was twisted on its pedicle, and this is a case of torsion that could have been called from the CT scan. So for torsion, it is important to use Doppler, but I suggest not betting on Doppler to make the final diagnosis, as the presence or absence of arterial and venous flow is not reliable in making the diagnosis. It's more important to check for asymmetric ovarian enlargement with enlargement of the affected or torsed ovary. That ovary may appear more echogenic due to hemorrhage within that ovary. You may see follicles that are displaced peripherally. But more importantly, to check the location of the ovary, to see whether it is twisted deep into the pelvis, into the cul-de-sac posterior to the uterus, or anterior and superior into the midline above the uterus. Moving on to pelvic inflammatory disease, it is important to point out that these patients may be confusing and confused with torsion, as they may also present with pain, a large complex adnexal mass, but also important to know that patients with both torsion and pelvic inflammatory disease can present with leukocytosis and fever. Pelvic inflammatory disease includes a spectrum of abnormalities including endometritis, salpingitis, pyosalpinx, tubovarian complex, and abscess. The findings are usually bilateral unless they occur due to direct extension, and the source is almost always ascending from a lower tract infection. Features include indistinct ovary and uterus, thickened fallopian tubes which may sometimes dilate and fill with pus. This may extend to involve the ovary, where one may see a complex adnexal mass, and the involved tissues may present with increased Doppler flow. Here is a patient who presented with pelvic pain. Because of the diffuse nature of the pain, a CT was obtained. The CT was read as stranding or inflammatory changes on each side of the and in front of the bladder, but no other findings to explain pelvic pain. A transvaginal ultrasound was performed, which was originally read as negative. Now, when looking back at the CT, there are enhancing soft tissue lesions that are separate from the ovary in the adnexa bilaterally. And on closer look of the ultrasound, we see the normal appearing ovary, the normal appearing contralateral ovary, but extra soft tissue adjacent to this ovary. And perhaps we may say in retrospect that there is complex fluid or a sliver of complex fluid anterior and posterior to the uterus. Now here we see the normal ovary, but the extra soft tissue that is above and adjacent to the ovary. On the other adnexa, we see a normal ovary, but again, all this extra soft tissue that is adjacent to the ovary. Doppler of this extra soft tissue demonstrated increased vascularity, excluding blood or pus as the etiology, and helping us make the diagnosis of inflamed fallopian tubes in the setting of salpingitis. When the extra soft tissue or the inflamed fallopian tubes is more severe, it may sometimes cause the appearance of the indistinct pelvis. It is difficult to separate, in this case, the ovaries from the uterus from the fallopian tubes. This may sometimes be difficult to distinguish from blood or pus, but with Doppler we can tell that this is vascular material, vascular tissue representing the inflamed, thickened fallopian tubes in salpingitis. Now the upper report in that case described pus around the uterus, and perhaps in retrospect we may see that the uterus is a little indistinct and there may be a sliver of fluid around the uterus. This is a difficult diagnosis to make and is more commonly made in retrospect. Now when pus fills and dilates the tubes, we get a pyosalpinx. This presents with thickened cysts and cystic masses in the adnexa. When you try to elongate this in a separate plane, you may see that these are elongated into dilated tubes, and sometimes a cine clip may help and show that these cysts interconnect.